Well, it's really a pleasure and honor to be here today. I'm very thankful for the Society of Vascular Surgery hosting this World Federation of Vascular Society session. This is our second World Federation session at the VAM. We've held many others around the world. In India, we'll be having one in South Africa in August. We had one at the VAM23 last year. And we're just building and growing. And I'm really honored to have one of our original presidents, Peter Galitsky, here, and many other supporters of the World Federation. And we're very appreciative of you getting up at this early hour to join us. I'm the World Federation Secretary General, Palma Shah, and I'd like to introduce our Vice President, Dr. Prem Gupta, who will start the announcement.
Good morning, everyone, and thank you for being here so early. It's good to see a reasonable audience for this hour, and I'm happy to see a past president of World Federation, Peter Galitsky, and the current president, Philip Cole. And we'll get the session going. There is a variety of talks, like it just represents the variety across the globe. So we'll start with Philip. ESVS Global Burden, he's representing ESVS. And he will speak to us about the global burden, pattern, and management of CLTI patients across the globe.
Thank you very much. Thank you for the honor of opening this session, and I'm very pleased to serve as the current president of the World Federation, and I take this opportunity to thank Prem and especially Palma and Joanna for their outstanding amount of work over the last few months and years, and still a lot of projects coming. You know that a few years ago, we published joint guidelines on the management of chronic limb-threatening ischemia, and we call them Global Vascular Guidelines. For various reasons. I think the first one is because they were the first guidelines developed jointly by the SVS, the ESVS, and the World Federation of Vascular Societies. And I think the contribution to the colleagues from the World Federation brought a lot of additional value. Global representation because we included 58 authors from 24 countries. Let me remember briefly what is CLTI. CLTI used to be called CLI and still called CLI by some authors. Also, for example, in the European Journal, we mandatorily ask the authors to use the term of CLTI. It includes a wide spectrum of disease with patients that have documented peripheral arterial disease and any of the following: ischemic breast pain with confirmatory hemodynamic studies, diabetic foot ulcer, non-healing lower limb foot ulceration for at least 2 weeks, and a gangrene or gangrene involving any portion of the lower limb or foot. There were a lot of reasons to develop large guidelines on CLTI that are listed on this slide, and I will, for the sake of time, not read all of them. But I think you can see the diverse specialties provider in care setting are among those. The highly variable utilization of vascular interventions, the wide disparity in outcomes, a lack of consensus definition, which means that when we publish, sometimes we compare apple, pears, and cherries instead of comparing apples with apples, so it's very difficult to get to an objective consensus. So with Prem Gupta and Marit Venemo, who is the current Secretary General of the ESVS, we conducted a preliminary survey using various databases from the SVS, from the ESVS, and from the World Federation. And the World Federation urged its member societies to disseminate the survey among the members to ensure maximum response. It's preliminary, so we are going to refine it and do a second survey shortly in parallel with the colleagues from the BEST CLI trial and the Novo Nordisk Foundation who is supporting us. You see there the number of answers per country. It's a snapshot, only 107, but there are some interesting data that I will share with you in a minute. The highest numbers of answers were from India and USA. And here you can see further division in the continent with the various regions. Most colleagues who answered were vascular surgeons, although a few other vascular specialists participated also. How many will show you 3 or 4 questions? We asked probably about 40 questions. How many patients with PAD do you see annually? And you really can see a huge variation depending upon where you are. I will not read all the numbers, but you can see them, for example, here in the US from 60 to 2,000, or in Europe from 100 to 15,000. Could assume that probably some people answer for themselves and some answer from their center. That we could also assume. Second question, what is the age range for majority of your CLTI patient? Again, a lot of variation. With 60, 70 years is the most common answer in general, but youngest patient in India and oldest in Europe. What is the percentage of female patients? What is the percentage of CLTI patients who need primary amputation in your practice? Again, a lot of variation. What imaging modality do you use most frequently to plan surgery intervention for CLTI? Most popular, CT angio in Asia, Australia and India, MRA in Europe, DSA in South America and USA. Quite strangely, do you use GLASS, the Global Limb Anatomic Staging System for CLI, as we recommended in the guidelines? And you can see that only a small proportion, or actually about, let's say, 40% use it, and the USA was the place with the lowest number of answers. I could show you all the answer. I have it with me, but for the sake of time, in the next 3 slides or so, what are the key messages? The caseload is highly variable. The age, the youngest patient in India, the oldest in Europe, USA, or Australia. Regarding gender, there's proportion of women highest in Europe, South America, and USA, and lowest in India. The proportion of CLTI patients needing primary amputation, there was a very large variation across the centers, with the lowest proportion in the USA and the highest in India and South America. That probably also reflect the type of care that we can provide to our patient with CLTI. I already mentioned imaging study. In Asia and in South America, the majority use the GLASS grading. In other regions, minority of the reporting centers use GLASS. There's similar pattern in discrepancy using the risk calculator. The majority in Asia and South America do use it. The Wi-Fi is used by the majority in most countries, except, again, quite strangely, but again, how much is this snapshot representative? We'll see in the next survey, except in the USA, where 50% of centers reported no use of Wi-Fi. Could say it's strange because actually the Wi-Fi came from the USA, as it was published in 2014, if I remember correctly, of the GVS, with Joe Mills being the first author. Endovascular first strategy was the most common strategy in India and South Africa. In other countries, the majority reported that endovascular first, it's not the approach for CLTI. For bypass surgery, in addition to the greater saphenous vein, synthetic graft is the preferred conduit in many centers, while for below-the-knee bypass with the greater saphenous vein was preferred. When there was no GSV, the contralateral vein is the preferred conduit in all countries when above-knee bypass is in question. When below-the-knee bypass is needed in case of no conduit, surprisingly, endovascular approach is the most preferred alternative. No center reported arm vein as an option. Drug-eluting technology is accepted in both segments, and arm veins are used in about 40% of centers. Finally, and not surprisingly, there was a huge variation in procedural costs across countries and centers. The percentage of patients who pay out of pocket is quite different. You can see from less than 10% to up to 80%. In most places, patient is under surveillance until the wounds are healed. About half of the replies indicate the best TLR trial has changed their practice. If the answer was no, the reason where they were already working according to the results of the trial, or they still believe in the end of first approach. And to conclude, I would like to emphasize that we need a new version of these guidelines. We have a lot of areas for update, again emphasizing the wide variation across centers. We have more validation studies on the grading and the staging system. We have various medical and post-procedural management data, and we have new data from numerous trials, including, of course, the Basel II and the BEST CLR trial. We have new data on the safety and effectiveness of drug-coated balloon and drug-eluting stents, or pedal artery intervention, and also on non-revascularization treatment need to be better addressed. So to conclude, I think there is obviously a huge variation of CLI pattern and treatment across the globe. Thank you very much for the privilege of the floor.
Thank you. So we'll hold questions until the end at the discussion. And I'd like to introduce the next speaker is representing the Society for Vascular Surgery, Dr. Wei Zhao, tailoring CEA, TCAR, and transfemoral carotid artery stenting to improve clinical and cognitive outcomes. And as she's walking up, I just want to say this is the first World Federation session where we have every society represented. So this is really very exciting. So everybody should be complimented for making this long trip to be here today. Thank you.
Thanks, Palma. I'll try to be brief. So although the carotid endarterectomy is considered standard of care, carotid did lots of clinical trials, including this ACLT 2, that randomized clinical trials show that carotid stenting just as effective. So there's similar results, MI and stroke rate. And the stenting group had a higher rate of non-disabling stroke. Now, in the long run, most of the clinical trials have shown that have similar stroke and death outcome between carotid stenting. That's transfemoral stenting and CEA. For the TCAR, it's not straightforward, and their industry-sponsored trial showed that the TCAR procedure has similar results as CEA. However, reporting standard can be somewhat controversial. The per-protocol analysis was reported versus intent to treat analysis. Now, despite that, there's lots of registry data from VQI show that TCAR has similar results as CEA, and with transfemoral stenting being higher risk in stroke and death. So because of that, TCAR has received a very rapid adaptation in the US. And if you look at this trend that was published several years ago, there's increased TCAR account for the total revascularization procedures in the VQI initiative. And that has continued rising. So now it comes to, there's three type of procedures for patients with carotid disease. What we really need to do to improve outcome is really to identify the high-risk features. This is not a surprise to anyone. Symptomatic patients at higher age tend to be high-risk feature that we can't really, there's really not much way you can select different procedure. However, for CEA patients, there's a high-risk anatomical features that you can potentially try to avoid. And for transfemoral stenting and TCAR procedures, calcified lesions, that's not really good for any stenting procedure. And then for hostile neck, you probably try to avoid the stenting CEA procedure. Well, the transfemoral stent could be a better procedure. So with that said, I think most of the surgeons have tried to select right patient for right procedure clinically. In addition, we also need to consider cognitive factor carotid disease, which is a huge economic burden. And this is the first 1,000 patients from CREST-2 trial, which you can see, patient with severe carotid disease, asymptomatic patient has a severe, has a low cognitive measure compared to age match control. And then in general, carotid intervention does improve, has positive income on cognitive outcome. However, there's a study have shown fairly inconsistent findings. Some studies have smaller numbers and short follow-up. And this is a system review from Ross Naylor now. Again, for what's considered as a high long-term outcome is 6 months outcome or more. And most studies show improve in one or more measures, and a few studies show decrease, deteriorate in one or more outcome measures. When we look at our data, about 170 patients, we actually see a consistent improvement in executive measures in all, in both post-op, 1 month post-op, 6 months post-op, and 12 months post-op. That's fairly consistent across different measures in executive function. For episodic memory, which is a more sensitive measure in patients with mild cognitive impairment, you can see there's improvement in 1 month and 6 months. At 12 months, there's no, the improvement had returned to normal, but there's no significant decline. However, if you look at individual patient level, most patients did improve. And what you can notice from here is at baseline, most patient has a below standard memory in patient with carotid disease, almost 1 standard deviation compared to the age-matched control. And after intervention, most patients have improved, but there's about 1/3 patient has declined. One of the most common reasons, likely subclinical microembolization, is fairly common, between 25 to 70% in patients, more so in the carotid stenting group. And those patients, even though have no neurological deficit, they do see this, hyperintensity on DWI, MRI, which shows abnormal diffusion water between intracellular and extracellular matrix in the dying cells. So when we look at this microembolization, several studies, including ours, have shown those microembolization is associated with cognitive deterioration after carotid intervention, both in the short term and also in the longer term. We look at the risk factors for the DWI lesions, basically for patients with a for stenting patients, bulky, calcified, short lesions tend to have higher risk for DWI embolization. We did not see any risk factor for carotid surgical CEA group, but this is systemic review showed that there are some risk factors for DWI lesions for CEA. It shows 68% was symptomatic. Patient symptomatic status was risk factor for DWI lesions. Patients have impaired hemodynamics and increased inflammatory markers. Those are the areas that need more research. And as far as the carotid stenting, TCAR, there's not lots of information. Some studies are fairly small in numbers. Nonetheless, TCAR have shown has a very similar intraoperative embolic rate than CEA, with the transfemoral stenting has a much higher rate. One thing one need to remember to look at the timing of the embolic rate is really at the time of the flow reversal. It's at the time that you finish the procedure, you restore the flow, antegrade flow. And with that information, one need to wonder what happened afterwards. And this is an older study by Joe Rapp's group, which showed that the embolization after short stenting can continue occur up to 48 hours and typically higher during the first 24 to 48 hours. So we need to really consider that when we think about transcarotid or TCAR procedure. To study a little further, we look at the volume of the embolic lesions, and then I'm going to go really, really fast on that. So basically, the larger volume lesions tend to have a more cognitive impact than small volume lesions. And then when we look at the risk factors for the higher volume lesions, and age and obesity predict large volume lesions in the carotid stenting group, and antiplatelet agent actually predict smaller volume in the stenting group. And then for the CEA, diabetes predict larger embolic volume in the CEA group. And so in summary, identify high-risk features for each interventional type can help to stratify patients for better interventional outcome. Now, cognitive outcome is equally important in managing patients with severe carotid disease, can have a huge socioeconomic impact in the future. Thank you.
I would now like to invite Dr. Nihar Ranjan Pradhan, representing the Vascular Society of India. He heads the department at AIG Institute in Hyderabad. He will speak to us about tibial artery angioplasty in the Indian scenario, a really important subject because we are really facing a pandemic of diabetes.
Good morning. Good morning, everybody. So, like my previous talk, nicely the critical limb ischemia. In this tibial artery angioplasty in Indian scenario, it is because of lot of calcified vessels. We have to do the multi-modality like angioplasty, and apart from that, medical therapy, all I'll tell in detail. So this is a study done, published in the Circulation, where it is way in 2009, where the tibioperoneal outflow lesion angioplasty can be used primary treatment. It is a nice study. And coming to Indian study, there is a nice study published in southern part of India in the SRMC Sri Ramchandra Medical College, where they found that the patients of around 65% of patients, they were having the tibial artery disease, where the tibial angioplasty was good. But the problem was, majority of them was uncontrolled diabetes. So recurrence was very high on those patients. But at least by doing the angioplasty, they found the ulcer size reduced, and there is the temporarily relief of the symptom, though recurrence chance is high on those patients because of uncontrolled diabetes. This Buerger's disease, we are seeing a lot of patients with, apart from the smoking, the chewing of tobacco also causes tibial artery disease and Buerger's disease, where the vasculitis, it is causing more in the little younger age group, around 40 to 50 age group, where apart from medication and stoppage of the tobacco, we can control the ulcer size or the pain by doing few patients with angioplasty of the tibial artery. But the result is we are getting, if they stop tobacco completely, and apart from that, medication, there the result is good, along with tibial artery angioplasty. So if you see here, this the chewing tobacco is more, and though smoking is also there. Okay, you will see here is a patient where the angioplasty in the TAS D lesion. If you see the third picture with the angioplasty, the flow in the foot is very good. But this is the problem. The limb salvage and amputation-free survival did not change if the case selection is not important. That means the angiogram, one of our senior vascular surgeon almost a decade back did a nice study on angiograms, and it is published also, where healing is more likely after direct revascularization of the correct angiograms, and angiogram concept helps explain the variability in the result of angioplasty for critical limb ischemia. So you can see here concept introduced in 1987, and there is 3 zones supplied by specific source arteries drained by specific veins. So based on the anteriotibial, posteriotibial or peroneal, if the pedal arch is good, then only the tibial artery angioplasty is helping those patients. You can see here. So depending on the which angiogram is present, if we'll do angioplasty of that segment, then it helps only. So where is the cursor? I want to play it. Where is the cursor?
I don't know. Is it touchscreen?
Can we have some help with this video?
Is there a
Yeah.
mouse or something?
I need a cursor.
Well, there's no mouse.
Yeah.
Yeah,
Yes.
Oh, it's fine. You just push it.
it's coming near.
Yes. So you can see here the first picture where it is showing that there is both anterior and posterior tibial artery stenosis there, and after balloon angioplasty, you can see the Yes. So the ulcer healing is worse in diabetic patient compared to non-diabetic despite obtaining similar patency rate. So success in revascularization seems to be only factor to affect wound healing in the patient despite the long segment occlusion. So the mortality in diabetic patient with peripheral arterial is higher in non-diabetic patient. Amputation, which has been found to be a major determinant of mortality. And the mechanism of anti-ischemic effects of prostaglandin E1, where has been used in the treatment of peripheral arterial disease, mainly in patients with non-reconstructible peripheral arterial disease, and also as an adjunct when there is residual ischemia after revascularization. So patient selection is very important, where we cannot do any bypass surgery or angioplasty there, or addition to our angioplasty, we can give prostaglandin. In India, we are giving and we are getting good results. But the scenario of how to give, there is doctor to doctor, it varies little bit. But in general, we give low dose, both in twice a day, at least 3 to 5 days. So to conclude, every recoil is frequently observed in critical limb ischemia patients undergoing tibial angioplasty and may significantly contribute to restenosis. Angiogram's concept of revascularization along with podiatric care and cessation of all form of tobacco and strict control of blood sugar is very important, and continuation of antiplatelet, statin and NOAC, that is rivaroxaban 2.5 mg twice daily as per the COMPASS trial, and net clinical benefit of low dose rivaroxaban plus aspirin as compared to aspirin in patients with chronic vascular disease. Thank you.
Thank you. Thank you. Our next speaker is representing the Japanese Society for Vascular Surgery. Dr. Takahiro Suzuki will discuss remodeling of the proximal zone and sac shrinkage after EVAR or FEVAR.
Thank you for Chairman. I would like to talk about the importance of aortic neck dilatation in EVAR and how suprarenal shearing gives FEVAR an edge in the postoperative sac remodeling. Sac shrinkage after EVAR is an important factor associated with good prognosis. Current Japanese research topics have been focused on type 2 enteric and postoperative growth. Aortic neck dilatation can lead to loss of the proximal shield, resulting in type 1 enterics and further secondary interventions. It has been classically believed to occur as a result of the radial force over graft and other factors possibly including intention. Despite the critical importance, relationship between proximal shearing zone and sac remodeling have been less described in EVAR and much less in FEVAR. This study investigated postoperative remodeling in the proximal shearing zone and sac shrinkage for AAA and FEVAR for juxtarenal AAA. The study design was a retrospective review of prospectively collected data between 2014 and 20. 33 EVAR cases without any IFU violation in proximal shearing zone were chosen from all excluded cases of 233. 15 juxtarenal FEVAR cases using female were chosen from all female cases of 39. The quality of their proximal shearing zone was equally healthy to the EVAR group. Follow-up imaging study was mainly performed by constructed CT or plain CT in combination with duplex scanning. Neck dilatation was evaluated by the postoperative diameter measurements, which encompassed 0, 5, 10, 15, and 20 millimeter below the most proximal shearing stents. The primary endpoint was to compare the extent of aortic neck dilatation and sac remodeling. Secondary endpoint was to investigate the other outcomes, such as enterics and secondary procedures. There was no significant difference between both groups, except the statin use. FIBA has significantly larger proximal shearing zone diameter and long lengths than EVA. No significant difference was found in the longest follow-up time and re-intervention. Neck diameters dilated larger in FIBA than EVA. There was a statistically significant difference between EVA and FIBA in the tracking result of proximal shearing length. EVA lost 8% of the proximal shearing length. On the other hand, FIBA was able to preserve the graft oversizing by 30%. All types of type 2 endolytic were found less frequently in FIBA cases. The lumbar arterial type 2 endolytics after FIBA occur less frequently in the acute phase. EVA had 50% of accumulated occurrence of sac shrinkage in 4 postoperative years, while FIBA demonstrated a greater level of sac shrinkage and a superior level of sac stability. FIBA had an advantage over EVA in similar aspects. Various authors have discussed aortic neck dilatation concerning FIBA. Various factors can be associated with the postoperative sac growth. For example, type 2 endolytic, end tension, and beta proximal shearing. This study added a new finding regarding the beta remodeling after FIBA. Various levels of lumbar arteries are interconnected at the suprarenal level. It can be a source of the type 2 endolytics after EVA. The long shearing zone of FIBA have an ability to occult the endolytic sources. This may give FIBA an edge in the postoperative sac remodeling. The inherent limitation of a retrospective review of prospectively collected data, and this is not prospectively study. This study was a small sample size and short observation period. FIBA induced beta sac shrinkage in juxtarenal AAA than standard EVA in AAA. Mechanisms of the advantage may be partially experienced by the ability to reserve the proximal shearing length and the lesser incidence of lumbar arterial type 2 endolytic after FIBA. Thank you for attention.
We have Dr. Asha Malan as the next speaker, representing the Vascular Society of Southern Africa. She will also be hosting the next WFVS session in August in Cape Town. She's going to talk to us about training vascular surgeons, challenges we face in Africa. Dr. Asha.
Thank you very much for the introduction, and thank you to the organizers as well as the World Federation for this kind invitation. So sub-Saharan Africa is home to among the least developed nations in the world, with the exception maybe of South Africa. The average annual economic growth rate of the region is estimated at mere 5%, with about 43% of the population living on less than $1.9 a day. Communicable diseases such as malaria and tuberculosis rank highest in the region's disease burden. However, due to changing lifestyles, non-communicable diseases, including cardiovascular diseases, are on the increase. Sorry, can we just move down the notes?
The green button, I think there.
All right, there we go. Apologies.
No, on your left. Yeah, the green one.
All right, so the profile of vascular diseases in sub-Saharan Africa has changed in line with the global increase in the prevalence of obesity, hypertension, and diabetes. Not surprisingly, the prevalence of peripheral arterial disease in the sub-Saharan Africa is equal to or even higher than recorded in high-income countries. A high proportion of patients continue to present with end-stage peripheral arterial disease, largely due to the shortage of timely vascular surgical expertise. So undoubtedly, the vascular disease burden in sub-Saharan Africa is presently being underestimated. The reasons for this are the prevalence of HIV in Southern Africa, the largest number of individuals living with HIV reside in Central and Southern Africa. This viral infection has multiple vascular manifestations, including aneurysms, hypercoagulable states, macrovascular occlusive disease, and multiple forms of vasculitis, some of which require vascular intervention to save either life or limb. In the vascular surgical units in South Africa, the vascular pathologies associated with HIV now comprise approximately 20% of our workload, and this is increasing steadily. The prevalence of trauma continues to be high in Southern Africa, and as a result, vascular surgical expertise, particularly in addressing some of the more complex vascular trauma, is essential. Atherosclerotic disease burden develops in economically evolving populations. As a consequence, the vascular surgical workload can be expected to rise dramatically in this region. In addition, some evidence exists that the combination of atherosclerotic risk factors and HIV infection is particularly devastating. Southern Africans are affected by some vascular diseases that are not frequently found in other populations, including Takayasu's arteritis, intermediate-mucoid degeneration resulting in aneurysms, and vasculitis of the peripheral arteries in young men. There is no reason to expect that these conditions will decrease in frequency in the near future. So the South African population of approximately 60 million is currently served by a mere 65 vascular surgeons. Even though this does reflect an approximate 50% increase over the last decade, this proportion is still alarming. This is in comparison to a country like France, with a similar population of 67 million, but being served by approximately 10 times the number of surgeons. To make matters worse, out of our workforce of 65, only 13 of us are currently employed in the public sector, carrying 80% of the burden of disease. South Africa's vascular surgical training program, however, is well established. Because of the shortage of general surgeons in South Africa, vascular surgery is still considered a subspecialty of general surgery. Consequently, training of vascular surgeons require a further 2 years after completing a 5-year degree of general surgical training. Training is offered in 7 centers that can currently accommodate 14 local trainees. However, due to the lack of funding for training posts, a maximum of 2 to 4 vascular surgeons qualify annually, resulting in a net loss considering those who retire or immigrate. In addition, once qualified, the state sector is unable to absorb these surgeons due to budget constraints. However, training more vascular surgeons when the country's health system is not optimized is counterproductive. Roughly 8% of South Africa's GDP is expended on health, equally distributed across the public and private health sectors. This results in maldistribution in the availability of health professionals, access to health facilities, and access to high-end health services. This is also evident in the provision of vascular surgery, where poor and rural communities are most disadvantaged. So what are our solutions? We need to up our numbers. A recent evaluation concluded that the general surgical workforce in South Africa should be in the region of 1,000 to 1,200. This is estimated that between 12 to 15% of the general surgical workforce should be vascular surgeons. At the current rate of new incumbents, it will take at least a decade, at which time more surgeons will be needed. The need for public-private partnerships become more pronounced, with expert vascular surgical centers being funded for providing a training and widespread clinical service. An interim alternative proposal is to redefine the scope of vascular surgical practice in the Southern African region to allow general surgeons to perform less complex vascular surgical procedures. This will, however, need to be governed with care as not to compromise quality for the sake of quantity. So in conclusion, South Africa needs to reevaluate the need and provision of specialized vascular surgical care. An overburdened public healthcare system not only dissuades those destined for the public service, but dims the light of tertiary academic centers aiming to provide evidence-based tertiary healthcare. As a result, innovation is essential in managing all aspects of vascular surgical training and practice. Apart from the obvious need to develop more vascular surgical training facilities, a redefinition of what the vascular surgical scope of practice will result in more patients being exposed to appropriate levels of care in the future. Thank you.
Thank you very much. We have very similar issues ongoing here with training. It's interesting that there's such a parallel. Our next speaker I'd like to introduce is Dr. Nelson DeLucia. He's representing ACVA from South America, and he'll be discussing hybrid operations in aortic arch aneurysms.
Morning, everyone. Mr. Chairman, thank you, Palma, for the kind invitation. So I'm Nelson from Brazil, and my topic is hybrid solution for aortic arch aneurysms, but for the sake of representing Latin America, ALCVA, and this World Federation meeting, I did some research on the very interesting article. I just found it by this, due to this presentation. So I found this age standardized rate of death of aortic aneurysm, and we can see that South America is the highest age standardized rate of death in the world. We can see by the red dark of Brazil that we are very different from United States and Europe. But the burden of our aneurysmal disease and the treatment is similar to many other portions of the world. I'm going to present some cases that I thought would be interesting for this kind of presentation. So we know that aortic arch aneurysms treatment represent the last frontier in search of total endovascular solution. These are some cases we did with prosthetic modified by the physician, and a total coverage with a window for the denominated left carotid and a covered stent to the subclavian. But these are kind of very uncommon operations. This is also a total endovascular solution. The patient was a survivor of a pulmonary transplantation and had this pseudoaneurysm in the ascending aorta. So it was certainly a relief to the cardiac surgeons when we could do the coverage with a low-profile cuff through the subclavian artery guided by ultrasound, and was a very easy solution. But these total endovascular solutions are still not frequent. So the object of this presentation is mainly the management of this complex situation of aortic arch aneurysms by hybrid solutions. So we had from 2011 to 2022 53 patients. This is the distribution by landing zone. In the cases are patients like that. In the beginning of this experience, we were doing the branching from the ascending aorta with a bifurcated dacron graft. Here is the solution after endovascular coverage. This technique was modified by a dacron 8 construction of an epsilon graft. That's much easier operation to do the suture in the ascending aorta. And here we can see the wrapping of the aorta with the dacron fabric and the marker with a radiopaque marker to easy the deployment of the graft for the coverage. And here the final solution after the coverage. And classical problems, like when we have the left internal mammary artery to coronary artery bypass, then you have to do the reconstruction of subclavian artery. That was done. In this case, we can see, I prefer to do the subclavian anastomosis remotely in the delta pectoralis area, so we can construct a workstation to do then the choreoembolization of the subclavian artery. I'm very keen on using the saphenous vein to do this bypass. The cardiac surgeons don't believe that saphenous can reach this diameter and caliber, but it's very neat, and I decided to do that after one case of infection in this area that was just terrible. So, and this is another example of the branching after type B aortic dissection, and was completed with deployment of a T-branch despite the lumen very narrow and the dissected area, but the deployment of the T-branch was possible. And this is another very interesting case of a right-sided aorta with an aberrant subclavian artery, and the patient was with pain and impending risk of rupture. The deployment of two endoprostheses failed. Patient was still with a leak that we can see there and excruciating pain. Then we did the reconstruction with a sternotomy and the anastomosis of a dacron graft from the ascending aorta to the descending aorta through a left thoracotomy and circlage of the proximal aorta. Patient done well. So this is our distribution of aortic aneurysm dissection. The vertical here is the arterial substitute. As I told, there is 24% of saphenous vein. The mortality is still a little bit high. This is a very complex group of patients. And in conclusion, total endovascular solution at the area of the aortic arch aneurysm represent the last frontier to be overcome and are not yet available on a regular basis. The complexity and the proximity of the ascending aorta, cardiac and valvular physiology, a concomitance with cerebral extracranial circulation makes its management particularly challenging. And hybrid solution, merging open and endo operations, still represent a less invasive and effective solution for many patients with aortic arch aneurysm, mainly by derivation from the ascending aorta without extracorporeal circulation or by bridge from carotid arteries and subclavian to allow endovascular coverage of the dissected or dilated aorta. Reasonable results and can be offered on benefit of patients with this complex disease. Thank you.
I now invite Mark J. Jackson, the Vice President of Australia New Zealand Society for Vascular Surgery. He will speak to us about challenges for remote area vascular care, and don't we all face that?
Thank you, Chair People. Thank you for the opportunity to speak this morning. Welcome from the great southern lands of Australia and Aotearoa, New Zealand. I have a informal disclosure to make to everyone that I live in a very well-populated subtropical coastal region of our country, and it's quite a contrast with what I'm trying to discuss today. We also work in an extremely well-equipped first world vascular hospital with a vascular centre. But generally, Australia is a geographically very disparate nation with huge expanses of uninhabited lands, and by world standards, by far and away the majority of the land mass is either considered remote or very remote. The distribution of vascular centres within Australia tends to mimic where the population lies. Now, there's an international standard, we've heard a bit of that already this morning, that perhaps we should be looking for about 14 vascular surgeons per million of population. And in Australia, our current average is about 8.6, and only 2 of our territories, those there in South Australia and the ACT, our seat of government, have anywhere close to that. The majority of our vascular centres are huddled in the southeastern area of the country. And it's here where we probably have appropriate representation of vascular surgeons. But even in the state where I work, our ratio is falling down below the national average and is clearly inadequate. When we look at even more remote areas such as the Northern Territory, its rate of vascular surgical representation is only 4 per million. Now, this is a state which is twice the size of Texas, to bring some sort of contrast. Now, this is also, you may be familiar with Crocodile Dundee. This is 20 years ago as a fictitious character. He was from Walkabout Creek in the Northern Territory. There was only one Mick Dundee. He had a very big knife. But there's also only one vascular surgeon in the Northern Territory, and he represents or has to serve about 250,000 population. Now, this reflects the burden of disease and disease outcomes, particularly for diabetic-related lower limb amputation and for renal disease, as we'll see in a minute. And so the outcomes are related probably to remoteness and distance, as we can see here. Generally, poorer outcomes are found in the states that have worse representation or supply of vascular surgeons. But it's not all about distance. We see here that distance as a big factor, but also socioeconomic standing and the glaring gap that applies between non-Indigenous and Indigenous populations. We can see here that the lives lost to cardiovascular disease amongst the Indigenous or Aboriginal population are roughly double that of the non-Indigenous population, and the peak incidence of their cardiovascular disease is about 15 years earlier in their life than non-Indigenous population. Looking at renal disease, and I'll exclude the majority of this very busy slide, in the Northern Territory, the incidence of end-stage kidney disease is about 3 times that of the national average. And the prevalence of dialysis-dependent renal failure is about 5 times the national average. So in Alice Springs, which is in the centre of the country and at the very bottom end of that province, there's a population of approximately 490 dialysis patients. And it's the largest renal dialysis centre in Australia, and I'm led to believe perhaps the Southern Hemisphere. But, this is serviced only by one vascular surgeon with the support of general surgeons, nephrologists, and radiologists as well. Our own involvement in remote and regional service delivery involves a 4-hour drive by one surgeon, 1 day per fortnight, to a town called Toowoomba, which is the geographic, well, not the geographic, it's the centre of this Darling Downs healthcare district, which extends all the way out to the Northern Territory border. From Toowoomba, if you were to try and find a vascular surgeon along the Warrego Highway, which heads out towards Darwin, the next vascular surgeon is approximately 3,500 kilometres away by road. What we need to do is deliver improved models of care, innovative models of care, where we empower a lot of the day-to-day management of these patients to trusted allied health professionals. And this involves better delivery of systems, better education. Western Australia is the largest state. It's 4 times bigger than Texas. From Perth, which is the most geographically isolated capital city in the world, their services have organised outreach to the Pilbara, the far north, the Goldfields and the southeast in a much more organised fashion. But there's still only monthly or bi-monthly visits, and there are mixed and inconsistent contractual arrangements. They provide dialysis access, diabetic foot and wound care, amputations, and some varicose veins procedures. So these are the needs. The solutions, I don't think we know all of them, but we need improved models of care and improved collaboration. We need physician-led and multidisciplinary teams. We need to involve our allied health partners, and we need to accept a degree of procedural role substitution. Only centralised vascular centres can afford 24-hour access to expensive hybrid facilities. We need larger, more organised and mobile workforce. Our vascular board, similar to South Africa, can only perform certain manipulations in order to address these disparities. And we need commitment from governments, improved organisation of services and improved resources for our remote populations. Thank you for your attention.
And our final speaker is Dr. Stephen Chang, representing the Asian Society for Vascular Surgery, who will discuss insights from endovascular repair of the arch using custom branded endografts.
Thank you very much. Good morning, and thank you to be here. And thank you, Palmer, for putting this together. So I'm representing the Asian Society of Vascular Surgery. Asia, it's a land of opportunities. and I'm from Hong Kong. I'm here to share with you some of our insights of doing this relatively advanced diseases. As you know, the endovascular branch, repair the aortic arch to supplement Nelson's talk, is often lacking midterm results. The limitations are complications of stroke, issues of deployment, how do you get out of this if you have troubles, and how are we moving from there. Certainly in our part of the world, many of the patients are old, they're elderly, and they don't like open surgery. And nothing is more rewarding by seeing these patients 70, 80 years old recovering from a total endovascular solution. We know from these two large-scale databases in Europe and in the United States that the main issue of doing endovascular arch repairs would be major strokes, which comes to 5 to 7%. If you count the minor strokes, this issue can also come up to 10 to 25%. These are results in Queen Mary Hospital in Hong Kong, where I work. We've done up to date 31 patients. As you can see, the distribution on the pie chart, the majority are for aneurysms. There are some dissections, and there are some mycotic diseases. Most of these are elderly patients, the mean age of 70 years old. The 30-day mortality is therefore approaching 10%. 3 procedural stroke, subsequently 4 reinterventions for endoleaks and migrations, and 2 long-term aneurysm-related deaths. So we have access to 2 devices that we've been using, mostly the Coke double branch device, which is climbing up. We're also using some relay double branch, and you can see that lately we are moving on to endovascular 3 branch devices. If you look at the bottom, you can see the crosses represent the deaths. There was 3 30-day mortalities, and there were some late deaths not particularly related to the endovascular repair. 2 patients with late ruptures, one from distal migration, which is again not related to the arch, and the next one from sepsis related to a very bad mycotic aneurysms. So inside technique-wise, we've learned to use the IVC balloon occlusion, so we don't need rapid pacing. In our study of 20 patients that we've used this technique, we can do balloon inflation time was 65 seconds. The graft can be deployed in 16 seconds, and the mean duration of hypotension was less than 100 seconds, with a blood pressure target of 55 millimeters of mercury being reached in most of the patients, and recovery time of hypotension is very good in 33 seconds. So this seems to work without pacing. One of the 2 devices we use, as you know, the double branch device has a very flexible inner sheath that would direct the graft to the ascending aorta for placement. I like this because it's very easy to go and very easy to deploy, and you can see the markers actually deploy very accurately in this position, and you have the access from the carotids, cannulated 2 branches which are parallel, and may be a little bit difficult to ascertain which one you're in, but once it's done, it can be done very easily. The critic for this device is sometimes you mal-rotate this, and you can see the markers. If you get it on the inner curve, then it can rotate in a relatively difficult position, and the cannulation can be difficult. Like in this patient, who actually has to resheath it and unsheath it, and you can see the markers were all on the wrong side. The other device I've been using is the double branch device with 2 antegrade side branches accessed through 2 diamonds, and this is the deployment, and because of the conformance to the greater arch, sometimes you can see that it can migrate a little bit once you relieve the trigger wise, and this little migration can cause trouble for cannulation. You can, of course, use a 3rd branch. There's a 3 retrograde pointing side branch for the subclavian, and you have preloaded catheters that you can get into either the subclavian branch or the carotid branch, depends on where you want to access this, and that is the subclavian branch being accessed from below, and you cannulate the artery from below, and it's very easy to put in the 3rd subclavian artery side branch to complete a total endovascular repair. If you put the preloaded catheter into the carotid side branch, then you can get you out of trouble. If you can't cannulate accurately from the top, we can cannulate from below, grab the wire from the top, and then put in a integrate approach from the top using access from the contractor side branch. As a land of opportunity, we're moving towards a total endovascular solution. I know Andy is presenting this first in the well patient, but we are working on this 3 retrograde side branch from a total transfemoral approach to avoid carotid access. As other devices, we may have issues of endo leaks, we may have issues with branch occlusions that we have to address. This is the other problem of our cardiac surgeons doing very keen sending aortas, and we can see that more than half of our patients will not be suitable if they put in sending graft like this. In future directions, we can do this in patients with thrombus, shaky aortas, mycotic aortas. These are all promising. And just to remind you that we have very exciting devices coming up. This is a device in mainland China by Professor Guo, and it's done more than 60 patients already. So I think in conclusion, this is a good therapy for inoperable patients and probably recommended for high-risk patients, and we're moving towards a lower or intermediate risk patients. So I would welcome you to join me in the next ASVS meeting, which is going to be in Antalya at the end of the year. Thank you very much.
Thank you so much. We're not going to unfortunately have time for panel discussion, but you can interact and meet at the International Reception. That's this afternoon at 5:15 p.m. It's on your app, and it's in the atrium level, lower atrium, Town Square. So you can hold your questions for the reception. Thank you, everyone, very much, and wonderful presentations. Thank you.